What's vital is that this information provides us with a lens to study the quantitative data through in the next stage, which is the data interrogation stage. In this stage, we interrogate data dashboards, and these include clinical, workforce, and finance data. These data dashboards allow us to visualize exactly what's going on in our service, to explore complex cohorts, and to identify where changes and improvements could be made in that service. The third stage is innovation, and this stage is all about idea generation. It's about looking for and designing new models of care. And then we close with our final recommendation stage, which are presented at board level. You can learn about the rest of the stages throughout the whole of Clear Week, but for the purpose of this particular workshop, we're focusing on the first stage, which is the clinical engagement stage. Are you on the right slide? Sorry, yeah, that's the right slide, great. So as we've kind of explained in the previous slide, during the clinical engagement stage, we collect qualitative information from all staff and stakeholders interacting with the service. And to do this, we use qualitative data collection techniques, so interviews, informal discussions, focus groups, and clinical observations. We then analyze those data using a type of thematic analysis that some of you may be familiar with if you've done qualitative research methodology. But we need to be very considered in the way that we approach this, and this is for two reasons. Firstly, we need to recognise that each staff member will have their own unique perspectives of that service and of the issues. And secondly, we need to understand how the dynamics of the clinical engagement itself can influence the data that we glean from that process. The next slide, please, Suman. So let's explore point one in a bit more detail. We all have different perspectives. So everyone that interacts with the clinical service or system will view it through their own lens. They're going to be far more acutely aware of the issues that affect their day-to-day role and less aware of the issues that don't. So for this reason, it's really vital that we engage with all kinds of stakeholders, from clinicians to administrators, managers, service leads, and we interact with the disciplines that interact with that service, as well as support workers. And when we bring all of this information and all of these perspectives together, it paints a much more accurate picture of the service as a whole. And this is why we carefully plan our engagement with a diverse group of staff and stakeholders. Can you go on to the next slide, please, Suman? So not only do we need to be aware of our perspectives, but we also need to be aware of how our individual perspectives as Clear faculty may influence how we interpret the information we receive. So I'm going to use this example, which I'm sure some of you will have seen in the press. This was a dress that caused a lot of debate on social media about whether the dress was blue, there's no green there, gold and white, or blue and black. Some of you may have looked at the image and seen it as white and gold, and some of you will have looked at the image as blue and black. But who is right? Is there a right answer? Is there a truth, or are there just different perceptions of the truth? The way each of us perceive information is different, and that can impact upon how we interpret the information we gain from the clinical engagement process. Can I get the next slide, please, Suman? Recognizing that our individual truth is recognizing that our individual truth is influenced by our knowledge, experience, education, and interaction with the world is something called Constructivism. And this is what we call an epistemological stance. Constructivism contends that knowledge is a human construct. It suggests that people actively construct or create their own subjective representations of an objective reality. So to give the example of this dress again, the objective reality is that the dress is two colours. Everyone would agree that the dress is two colours. But our interpretation of the colour is more subjective, and to an extent a social construct. We might not see the colour in the same way. We have different words for the colours. The perception of the colour in this case was influenced by context, and that was the light, the amount of daylight around when the person looked at that image. Next slide, please, Seema. If we take this constructivism viewpoint, we recognise that each individual's interpretation of the same thing is going to differ. Therefore, their reality differs. And this may have a direct impact on their experiences and perceptions, and therefore the information that they provide, or indeed how we interpret the clinical engagement of that clinical engagement process. To just try and explain that point in a bit more detail, I think we can all agree on this slide that we can see a picture of a dog. But if you are a dog lover and you have a good experience with dogs, that picture might you might think, what a nice dog, what a cute dog. You'll have a positive experience of that image. If you've been bitten by a dog, you might see this as a threat and want to escape. Perception of what happens in clinical practice, perception of a service, and perception of the clinical engagement discussions will differ based on our beliefs and our experiences. This is something we need to be acutely aware of during clinical engagement, because if you look at things from a different point of view, your perspective of that truth will change. These perspectives, knowingly or unknowingly, are influenced by our identity and by our experiences. Our identity is defined by our traits, our characteristics, our social relations, our roles, and our social group memberships. And we have different types of identities. We have social identities. So, for example, you may be a member of a team or a book club, or you may be a member of a church. We have role identities. And these are particularly important within the clinical setting because our professional role may influence the clinical engagement stage. And the roles that we have will be influenced by our experience. So someone in a senior role will have more experience than someone in a junior role. And finally, we have our personal identities. These are traits or characteristics that feel separate from social and role identities and are personal to us. All of these influence how we see things, but also how we're seen. And we lean on different identities dependent on context. You would present a different identity on a first date to an identity you may present at a work conference, for example. Our perspectives will be influenced by our identity, and the identity we project will influence other people's perspectives of us. So with that in mind, what I wanted you just to do is take a moment to have a look at this riddle and try to solve it. And I'm going to ask you to just write your solutions in the comments box if you can. Actually, I'm going to change my mind on that. Just take 30 seconds or so to think about it in your head, because I don't want to give away the answer. And then I'll ask for the answer in a moment. Okay, can anybody explain the riddle? If you want to just write in the chat function. Very good, Claudia. It is. It's the surgeon's mom. Did everybody get that, or did anyone put anything else? So the solution is that the mother is the surgeon. Did anyone think anything else when they read this riddle? Silence in the chat. No one wants to admit to thinking instinctively, trying to struggle with the answer to that riddle. When I read that, I struggled. I didn't automatically come to the conclusion that the mother is a surgeon, because there is an unconscious bias in many of us that surgeons are male. And that's something that we some of us are very aware of and some of us are not. But this unconscious bias and this how we identify on our identity does have an impact upon our perceptions. When we're talking about our unconscious bias, what we mean, or implicit bias, what it describes is the associations or attitudes that reflexively alter our perception, thereby affecting our behavior, our interactions, and our decision making. And this is often something that isn't acutely aware we're not acutely aware of at all times. What we must try to do during this clinical engagement phase is recognize that when we carry out these conversations, these interviews, discussions, our unconscious bias, our roles, and our identities will influence the questions we ask and the information that we gain from that interaction. We can't remove this unconscious bias, but we can try to be aware of it. The awareness of unconscious bias is called reflexivity. What reflexivity means is that we, as effectively researchers in this setting, are aware of how our roles, how our beliefs, and how our unconscious bias may influence the research or the clear process. In terms of the data we collect, the data that is provided to us, and how we interpret or how we interpret that information and then thematically condense it down. Having this awareness can help us to plan our projects in terms of how we approach our clinical engagement, who engages with who within the CLEAR team, but also help us to think differently when we consider our findings. This is something we say to the CLEAR Fellows when they start on the associate programme. This process of trying to identify your own identity, your own roles, your own implicit thoughts, your own unconscious bias, it can be quite a raw and uncomfortable thing to do, but it's a really important part of the process. So we do encourage people to be reflexive in their time during the CLEAR programme. So what I wanted to do for this workshop was, with all of that in mind, I wanted to take some time to do a group task. And what I'm going to present to you on the next slide is a vignette of a clinical engagement discussion. And what we're going to have, I'm just trying to work out how many people are in the room. So we maybe break off, how many have we got here, Seaman? 10 or 12?
Sorry, let me 12 altogether.
Okay, if we have, if we could do 3 groups of 4, that would be great. What I wanted to do actually, if we've got CLEAR staff, maybe 2 groups of 4 each, is to work together to think about how these things, how your kind of unconscious bias may influence your clinical engagements discussions. Think about your backgrounds, consider your role identity, and think how that would affect how you interpret the situation on the next slide. Does it differ between the people within your groups? And what kind of format do you think would be best suited to have this kind of conversation with a clinician on the ground during that clinical engagement stage? What you'll also see in the next slide is that I've got a list of staff members, and these staff members are CLEAR associates. What I want you to do is to think about how that conversation may be influenced by different associates carrying out that particular engagement, how the information may differ that they receive and how they interpret it may differ dependent on their role. So I don't know if you want to just take a quick photo with your phone of that task, so you've got it in mind when you look at the next slide. I'll just leave it open for a moment. Could you go back to the tasks? Sorry. Yeah, if you want to take a quick photo of that, so you got it in mind when we go on to the next slide, which is the vignette. Yeah, and on the next slide, we've got this vignette. So our question is, if you move on to the next slide, Seaman. Thanks. So this is our vignette. So this is a clinical engagement discussion that's occurred on a ward and with a registrar. And the registrar has reported that the discharge process always takes too long. It seems to take forever for the therapy team to come and review the patient, and even longer if the patients then need equipment or social services. TTOs are usually delayed, and if the patient needs transport, they often have to wait for hours. I feel like as doctors, we're working as hard and as fast as we can, but when we're hanging around for therapists and pharmacists to sort it out, we've already said they're medically fit for discharge. It's frustrating, but what else can we do? So the registrar seems annoyed as though they report this, and it's said in an angry tone, and they have their arms crossed. I want you to read that, think about how you perceive that information based on your role, your identity, your unconscious bias, and then consider who out of this list of interviewers would be best placed to have that conversation, and how that information may differ based on the person they're talking to. So if we break out into breakout groups, we'll give you around 15 to 20 minutes to do that, and then we'll come back and discuss that vignette and see what you came up with. Hi everyone, welcome back. I'm just going to leave the slides off for now, if that's okay. Can you hear me?
Yeah.
Yeah.
Okay, great. I'm going to leave the slides off for now, if that's okay. I'm just going to get you into view so I can see all of the gallery view. I just wondered if anyone had any initial feedback about that and initial thoughts about the vignette and what your kind of initial reaction was from your particular background. If we could share that.
I'm happy to go.
Thanks, Claudia. Thanks.
Just to say, obviously, I was with Barry and Eve, and for me, it was that reading it and thinking, blimey, are we still there? Are we still in the same position? We've been there how many years, and we're sort of not moving forward. So I think, great empathy for the registrar, really, knowing where he was coming from. But also actually recognising, so empathy all the way, really, recognise that everybody's busy and trying not to let my own thoughts and views influence how that would go forward if it was an interview, that interview process, and making sure that I hold those back and allow others to have views and thoughts.
Yeah, what I thought was really, really interesting in our group. So I was, as Claudia said, with Claudia and Barry's from a finance background and Claudia's from nursing background, was it, you said? And both of them, when they initially read the vignette, Claudia's immediate reaction, as she just described, was attached to an emotional experience of having, well, not necessarily an emotional experience, but there was an emotion which was frustration, having lived through that and encountered that problem multiple times in the past that's still not been resolved. Barry, if you don't mind me speaking on your behalf, had said his immediate reaction was, oh, there's an issue with flow here. And they come from completely different backgrounds, but were presented with exactly the same information. But because Barry didn't have any kind of experience of those kind of difficulties clinically or those system errors, he was seeing it in a much more objective manner. So the information he may have gained from that may have been different to the information that Claudia may have gained from that interaction. But equally, the response from the registrar to Barry or to Claudia may have been different. If Claudia showed that empathy and understanding, that registrar may have felt that they were talking to someone that knew what the problems were, understood the problems, maybe more willing to give more information and dive deeper into things. And if they spoke to someone that didn't have a clinical background, then they may think, well, oh, it's going to take me so long to explain the frustration of this, that they may not continue to have that conversation. So they're just examples. I'm not saying that the conversation would or wouldn't go like this, but what we need to be very careful of is thinking about how our position and who we are influences what we hear, what we see, and how the other person feels. Does anyone else have any, did anyone else be happy to discuss the conversations they had within their groups?
I can feedback for Nicola and I think Nicola's on a bit of a weird tech situation, so with no microphone, but she was on a laptop earlier. I haven't been just talking to myself. But she was saying that she's come from she is in a HR role at the moment, so it was quite interesting for her reading it. And I thought we were just discussing about the people who were best placed to talk to that staff member, and it's probably nobody that was mentioned in the kind of complaint, so somebody that's a bit more removed from it maybe. And then we were also talking about formal versus informal setting, and we weren't sure what's best, because I guess if it's coming from a complaint way, it's probably best that that's formally logged, but then maybe you wouldn't get as much information out of somebody if it was in that formal setting, and maybe informal is better. So yeah, that we were kind of tossing and turning with that one. We weren't too sure.
Yeah, and the setting is really, really important. If you're sitting down with someone opposite them in an office and they feel like they're being interviewed, people may clam down and not be willing to share vital information, because what we need is, what are the issues with this service, and we need as much honesty and openness as possible. And so formalizing it, recording it, sat down face to face, may shut people down. They may not have time to meet with you. You may be better having a kind of informal discussion on the hoof when someone's in the clinical setting to try and get that information. But considering that is really important. Equally, the focus groups that we run, we have to be really careful about who we put into those focus groups and what the objective of that focus group is. Because what we want is, we want to understand the most the service issues, but the objective reality, if you like, of that system problem. If we take everyone's individual kind of subjective experience, we can pull that together to give us a clear overview of the issues that we can then take forward and challenge our quantitative data with. How many groups did we have, Seaman? Does anyone else in any other group willing to talk about their conversation?
Sorry, there should be one more group.
I'm happy to talk about the discussion in my group.
Thanks, Becca.
Fab. So again, just a small group, just two of us. And it was quite interesting because very different backgrounds. However, most of the conclusions that we drew were quite similar. So originally reading it, my initial perception was very much action orientated, solutions focused. My background is program management. So I work with different clinical services all the time and help them solve problems and make improvements and change processes and make things better. And support them with that process of turning whatever vision it is that they've got into a reality and actually making it happen. So for me, the first thing that came to my mind was, how do we resolve this? What do we do? How can we address it? How can we make it better? And while we were discussing the roles, I think what was mentioned in one of the previous groups was very pertinent, in that actually there's some animosity demonstrated already there towards therapy and pharmacy. Is that going to create friction from the outset? Is that going to be kind of an us and them point of view? And then also we had a discussion about the clinical perspective. So if it was the Band 7 nurse, would that person also hold very similar views, as in, we're doing everything that we can here on the ward, we're very focused on the discharge, this patient's medically optimized, they don't need to be here, we need to get them home? Will they view the situation objectively and see those other dependencies and recognize the complexity within those interfaces? Or will they just have a similar view, this isn't right for the patient, this isn't the right outcome for them, this isn't what we should be doing, and feel quite angry? So we kind of deduced from that it was that clinical service lead role that might be best to lead on that, for the reason that they've worked in an environment where they've had targets, they've had pressures, the performance has been key. Even things like financial budgets and all of this stuff, they're used to having that pressure. However, also managing that service, they'll be familiar with and aware of all of those interdependencies too, and the fact that how frustrating it can be when things are out of your hands, and also have that insight into maybe how some of that's been resolved previously. So that was kind of where we ended up thinking.
Yeah, that's thank you for saying that. You brought up some really interesting points there. I think the first point you said that your background made you automatically go to solutions in terms of, because that's your role and what you do. And so that in itself is an interesting point, because one of the things that we try to avoid is going to solutions too quickly. Once we have done the clinical engagement stage, we then would do our data interrogation stage. And at the end, we do a process called triangulation. And in the triangulation process, what we'll do is we'll take our qualitative data, so the information we've received from the staff, and we'll look at our quantitative data and say, does this actually support each other? Is there an issue, a delay in the drugs being given to the patients to take home? Is that actually delaying the discharge? Can we see this in the data that we've got? Do they corroborate? And it's at that point we'll then say, yeah, this is definitely an issue. We're going to take it forward. And what's interesting is that in one of our recent UEC urgent emergency care projects, they've been quite surprised that actually what they thought was an issue wasn't an issue, and things they didn't think were an issue were an issue. So it's really, so we try and encourage people to keep the innovations jotted down, the ideas jotted down, suggestions jotted down, but still try and keep an open mind as possible until we get to that innovation stage of the project. And the other thing that you brought up, which I also thought was interesting, was about the potential for an associate to become defensive if they felt like it was a criticism of their service. That's and I think that the important point here is that all of our associates, because we're a clinically led program, all of our associates are clinicians generally, or within the current CLEAR projects anyway, and they're embedded within that service. And there is a risk that they kind of have two roles. They have two faces within that service now. They have their clinical role, and then they have their CLEAR associate role. And making sure that they maintain that objectivity to an extent whilst getting the right information is key, because there can be a bit of a conflict between that, and managing that conflict is really, really important. So I think I would have come to the same conclusion as you, Becca, to have the service lead talk to the registrar, because I would have thought you might have got a more kind of honest kind of, almost brutally honest kind of description of what their frustrations were. But again, it may be down to the personality type. So when we're doing these projects live, the people know each other, so they know who the clinical lead is, they know who the registrar is. So we also don't just factor in their job roles, their job identity, but also their personality, like considering what information they may be able to get from their colleagues. There is a risk that people that are associates try and talk to their friends first, but that can be a bit self-fulfilling, because then the concerns you have, you just corroborate with the people that have the same beliefs as you. So we encourage this purposive approach to sampling, which means that we're trying to get views from really people that really disagree with each other. We want to know those that are really pro something and those that are really against it. We want information from both of those people, because there's probably some truth in both what they're both saying, even though they may have completely contrasting views on it. So thanks for those comments. They're really, really insightful, and exactly why we talk about this and teach this on the CLEAR program, just to plant the seeds to get people thinking about how they can get the most out of the engagements that they're having. Okay. Nicole, have you got anything? Sorry to put you on the spot, but which group were you in? Were you in with Charlotte?
I was in with Becca, so yeah, she's very specifically just summed up what we discussed in our session.
Fab, thank you. Okay, cool. So I guess, Suman, would you just be able to share the slides again? Has anyone got any other comments before we kind of round up from this? I realised that was kind of a very, oh, could you move on to the next one, please? And the one after, actually two, I think. Yeah. So I'm just going to close the session there. I realised that was kind of a very brief overview of what we do in clinical engagement, but hopefully it was just useful just to get people thinking about what conversations you can have when you're doing change initiatives and service improvement, and how those conversations may be influenced by who you are and who you're talking to. So just really to summarize, it's just to say that these perspectives that we talk about are going to be shaped by our identities and our experience. And we use this term reflexivity, which is the recognition of how these experiences and identities influence the engagement process. And awareness of this is really, really vital to making sure that we get as good information as we can. And there's no right or wrong answer. It may be personality dependent. You all know each other, which is a strength and a weakness in some ways of the CLEAR program. So there's no right answer, but it's just making everyone aware of who they are and what role they play and how that impacts upon the information that they get. So there's a few references if you wanted to have a read on the next slide, and I'm happy to take any questions that you might have. And I hope that was a useful session to attend, and thanks for coming.